This represents cross-agency working at its finest. You can see at the two extremes of the photograph, you've got my ugly mugshot, and then far better looking on the far left is Joy, our age concern officer. And right in the middle is one of our wards, is our ward sister Sharon. So we started off, for example, it was the doctor's office, the nurse's office, the social work office, the home care office. And we very quickly realised that the key to partnership working is actually integrating even more fully. And hence, as a result, swapping it all around so that we all share offices together. And it's been a real eye-opener for me to share an office with Joy, because I get much better information on what she actually does. Sitting down, for example, one day I was just answering doing a clinic letter, etc. And Joy's on the phone to a funeral director who apparently, after talking to her afterwards, was acting a little bit in an unscrupulous way. But she was such an advocate for that lady whose husband had passed away, and stuff like, I think you're taking advantage here now, and I think that you can do a far better deal than what you're. I said, whoa, this is so, because we never think of doing that, and it's particularly when someone is vulnerable, lost her husband, and from my perspective, she had mild cognitive impairment, so she was able to function on a day-to-day basis, but her higher executive functioning, in other words, her ability to make really incisive decisions about stuff that's relatively complex, managing financial situations, looking for the best deal, everything from getting the best deal for your fuel supply to your television supplier. I've seen Joy in action now, and she does a tremendous job in that respect. So it's, and that's the stuff that brings what I should call life to years rather than years to life, which is kind of my end of the spectrum. But as we rightly point out, there's little point in living longer unless you've got that bit of quality to your life. So that's the cohort of the team there. You've got doctors, nurses, therapists, dietitian, physio. We had a bit of podiatry, but now we do virtual podiatry now. I'll leave that to your own imagination, but it does work. And then our partners, obviously, the local authority, we've got excellent integration with our social work colleagues in the same building as well. And then, as I say, Joy from Age Concern, who she crosses those boundaries between primary sector, or the primary healthcare sector, and the secondary healthcare sector, because she works in the hospital setting as well. So I almost see her as a mirror image of myself, except that it's a very different skill mix that she brings to the table. So this is the old previous model of intermediate care working, where you've got the primary care set up on one side and the hospital on the one side, and the circle around it represents the wall. And then there's walls then to accessing other services. So the small little bubbles in the middle represent other services, like, for example, I would see the hospital discharge team as one of the bubbles, for example. The acute response team could be another bubble, the reablement team, etc. And they've all got their own criteria in terms of accepting patients, excluding patients. And very often you'll find patients ending up in the space between those bubbles where they don't neatly fit into any bubble. And it's very difficult then to try and cross that the boundaries for them to access the care needs that they need. So this is the way we work in the Celtic model. We try and reach into the hospital setting, so we overlap into the hospital setting. That's part of what I do, and it's part of what Joy does. She works down in the A&E department, identifying patients who may be suitable to come out with the Celtic case mix, and I'll give you an example of a patient on that in a moment. And together with our local authority and voluntary, and as I say, with Age Concern, we work right across the pathway, because frail older people are constantly moving across these three bubbles. We try and keep them in the middle bubble, where they don't need doctors, where they don't need nurses or hospitals, and where they don't particularly need to be in a clinical setting. But invariably, because of what's called reduced physiological reserves, as you get older, your reserves get a lot depleted, and little things that you would have tolerated as a younger person can knock you off your pedestal very quickly as you get older. So we reach into the secondary care setting to pull people out of hospital before they become entrapped or before they become embedded in the system. And similarly, we reach into primary care to try and grab those patients who are on the brink of failing for whatever reason. So this is an example. In the UHB I work in, there's two patients. Their names are Tom and Mabel. And they represent lots of different people of quite wide diversity as a result. But this is an example of a lady who was in hospital 5 times in a previous year. Had spent pretty much most of the year in hospital. And we pulled her out of the medical rehabilitation unit in the Royal Infirmary. And within a couple of days, she'd fallen over. And at that stage, I went and seen her, saw that there was nothing acutely wrong, but it was clearly she was unsafe to be left at home because she didn't have capacity on the decision to continue to live in her own home. She didn't understand or appreciate or be able to weigh up the risks of independent living. Quite a traumatic time for her and her family. She didn't need to go into hospital, but fortunately, because we worked as a cohesive, co-located, integrated partnership working, I was able to ask our social worker in the same office to try and help organise emergency respite, which we did in a residential home setting. And from an age concern perspective, we were able to help take the family through what might happen next. And as it turned out, the lady herself absolutely loved it in this particular care home, and she didn't want to go back home. But then there's a whole lot of things that need to be sorted out, everything from what happens to your old home, what happens to old responsibilities, how is this to be financed, what happens should she deteriorate in the future. And that's the sort of thing from this lady's perspective, and particularly from her family's perspective, that Joy was able to really make a big difference. And not just Joy, I want to mention the other partners I work with out in the transitional care unit out in St. Mellons, where I also work with Bernie, another age concern officer, who does huge work in terms of helping patients and their families adapt and come to terms and basically see the positives of moving into a care home, because it's not a negative thing. Sometimes it can be a very positive thing, and quite often it is if it's approached in the right way. But there are patients who my number one priority is to try and keep people in their own homes for as long as is reasonably possible. But it does have to be taken into account that that's not always reasonably possible. But if it's done well, and if you've got a good advocate on your side, like for example Bernie or Joy, it makes a huge difference to families, because they don't see. That's the beauty of working with age concern, Cardiff and Vale. They don't see us as the bad NHS or the bad social workers, doing things that might not be in someone's best interests. So anyway, this lady, she loved it in a residential home setting, and we subsequently helped to facilitate her transfer into a nursing home when the time came. Unfortunately, the care home closed about 18 months later. That's another day's work. So if I pop to the next chap, then is Tom B. And this is a chap who'd presented his GP had sent him into casualty with weight loss. He was cognitively impaired, he had a couple of falls, and he was clearly failing to look after himself at home. When he was seen in A&E, the doctor says we'll have to bring him into hospital to be on the safe side, which is often not necessarily the safest thing to do. He was relatively unkempt, there was clear self-neglect evident, but there was no obvious acute illness. He didn't have pneumonia, he hadn't had a heart attack, he hadn't broken any bones, although his confidence might have been relatively fractured. And he wanted to go home and was felt to have capacity in that decision. He understood the predicament he was in, but clearly didn't want to stay in hospital. As you can imagine, this causes all sorts of concern amongst clinical staff, but fortunately Joy was on hand, and she was able to bring his presentation. He was allowed home that evening, but then the next morning at our C.E.L.T.I.C multidisciplinary meetings, his needs were discussed, and as a result we put full team support into him, everything from falls prevention to managing potential osteoporosis to managing the need for social care, particularly around the element of self-neglect and personal care. And then Joy did her stuff in terms of getting better deals, for example, on heating, making sure that he was getting befriending groups, etc. Advocacy in terms of, I think this was the chap actually who sorted out his Virgin TV account. But it's the sort of stuff that we in the local authority and National Health Service just go over our heads slightly, or we just haven't got the time or the resource to do that. And as I said, that's what adds the life to years rather than the years to life. And 6 months later, he's happily maintaining himself in his own home, albeit at reasonable levels of risk. There's always risk involved. So, I see age concern essentially in C.E.L.T. It's an integral part of the Celtic service. It does bridge the gaps between what the NHS and the local authority traditionally provide. It provides a focus on living rather than existing is another way that I look at the difference that age concern makes to the people that we work with and the people we look after, and adding life to years rather than years to life. It's meeting those with the most needs, as I say, and not those that shout the loudest, and that's a crucial part of the way we work in terms of the population that we serve, because there are different populations even in a city, or even in parts of a city, where people's needs are greater. And quite importantly, and this is the one that we particularly like when our hospitals are under pressure, is to help pull people out of hospital before they get stuck in a hospital setting. And the longer you're in hospital, if you don't need to be in hospital, then you start to lose more reserves. And it's almost like the Celtic Model. Various sticks that were supporting you in the community start to be pulled out, and those sticks might not be there any further. And you might have to put in new sticks then to get the patient back home again. I think that's the lot, is it? Except for feedback, Joy as well has... naturally, you have to evaluate your service, and I was delighted when we set the service up that Joy was able to independently look at what our service users, I love that term, service user, the people we look after were experiencing. You won't be able to read the fine print, but essentially the light green is excellent and the blue is very good across a wide range of things, everything from the experience the person had, how did they feel valued as a person, did we make a difference to their quality of life. So it was very positive feedback, and I was glad that it was Joy that was able to collect that rather than us in the NHS or the local authority perspective, although we could do it as well, but it's nice to have a more independent slant on it. So, final slide, I think. The successful partnership working from my perspective is co-location, being in the same building and practically in the same offices together, being as integrated as you possibly can be. Yes, a shared electronic patient record is very minor compared to cakes. Yeah, I put on about half a stone in the last couple of years, I think. So, but it makes that difference. Along with regular team meetings, training days, I do invite the occasional drug company, such as GlaxoSmithKline, to come and talk to us about various products that they might have. But we bring the whole team in. For example, if I have a drug company come to talk about an osteoporosis drug, well, the way I see it is osteoporosis is not just a doctor's job, it's right across the spectrum. So our home care team will tell me about patients who are at risk of falling or who have fallen. Our disciplines obviously try and reduce the risk of falling. And our age concern officer might be able to look into things like helping to see what the pharmacist is doing in terms of provision of medications. Are they being provided in easy ways to pick up? Is the person able to collect their drugs, for example? The other thing about the way successful partnership working is being able to be open to change. And that's one of the key things really about all the people who work in our C.E.L.T.I.C services, that we're all very open to change and new ideas. And as a result, I think we largely get along. Thanks very much.